Welcome back as we begin the last of our series here on the lymphatic and immune system, continuing on with the immune system here, getting into the last of our innate defenses and the inflammatory response. So whenever we have anything that is potentially harming the body itself, whether it is damage to tissues, whether it's in a pathogen of some sort that is causing uh, problems with the cells themselves, we have a situation where we need to have an inflammatory response. And with that comes four cardinal signs of inflammation. So we get redness in the area warms up, so it becomes hot. We see a swelling or an edema in the area. And then we have, of course, pain. And so we have four different processes that happen in the area to essentially tell us that something is going on there. And where this comes from is essentially a cascade of chemical mediators that is going to allow us to begin the process of beginning in the inflammatory response itself. And these are going to be released by the tissues themselves. This is going to be released by things like the white blood cells that come into the area, our lymphocytes, our phagocytes that are there. And that's going to stimulate the process of allowing for everything to come in to help to deal with whatever it is that is the problem, whether it's the tissue damage, whether it's infection by bacteria, etc. One of the first things that has to happen is we have to have blood vessels begin to dilate. And so this is going to bring in the blood flow. So this is going to bring in the heat. This is going to bring in the nutrients that we need. This is going to bring in the potential for fluid to kind of dilute whatever it is causing the problem in the first place. So that blood vessel that is now on the process of becoming dilated is going to allow for those capillaries that are locally in the area to become highly permeable. And so the permeability of the capillaries there is going to increase. This is going to allow for a couple of things to start to occur. One of the big things is that we have now a large amount of fluid that's going to start to come into the area. So this is going to be part of our swelling that's going to occur. It's going to be essentially attracted there by things like proteins and clotting factors and antibodies to help to kind of dilute the area that is there. And so that fluid starts to move into the tissues themselves. We start to get edema into the area. And as that fluid kind of starts to fill the spaces, it starts to push on nerve endings. And this can be what we start to feel as pain. And so we start to feel that pain there. So if it's something like a sore throat, we've got bacteria going in the throat there, we start to feel those processes occurring there because of that swelling that is occurring. The fluid that's now coming into the area, as I mentioned before, is there to kind of dilute what may happen to be there. So if it's an infection, we definitely want to dilute any kind of chemical toxins that are coming off of the pathogens themselves. We want to potentially dilute any kind of substances that are now in that fluid that's there so that it causes less harm. But with that new fluid coming in, it's also going to bring the things that we need to do repair. And so we're going to have a lot of nutrients coming into the area. We're going to have large amounts of oxygen coming into the area. This is all going to provide for the energy and the raw building blocks that we need in order to get that healing process to start to occur. So when it comes to this inflammatory response, one of the things that needs to come in is phagocytes. And so phagocytes need to kind of migrate into the tissue itself and find their way to whatever it is that is potentially harming us as far as pathogens or cleaning up the tissue debris that's there from damaged tissue, things like that. And so this goes along a kind of a four-step process. And so within the chemical response that we're getting, we start to get the production of leukocytes. And so we get leukocytosis. And so we have the white blood cells starting to become increased in their numbers and get released as a response to damage to other cells. And so injured cells elsewhere are starting to release these chemical signals that say, okay, we need some neutrophils to come into the area, start to clean things up. Once those neutrophils get into the area of the damage, kind of where the chemicals are at their greatest concentration, they're going to need to start to stop moving through the blood vessels, and that's where we get what we call margination. And so they start to cling to the walls of the capillaries in that area of damage. Now they need to get out of those capillaries, and so that process is what we call diapedesis. And so the neutrophils themselves make their way through the capillary wall, and they start to kind of wander into the tissue itself, and if they come across anything that's not supposed to be there, they're going to begin the process of phagocytosis. And so with that, to find those areas of damage, they follow chemical attractants, and this is a process called chemotaxis. And so they're following all of the chemicals that are out into the tissues themselves. And so we get this neutrophil coming from the bone marrow, and so we get our leukocytosis occurring. They find their way to the area of damage. They start to cling to the walls, and we get margination. They start to wander into or literally walk through the tissues. We have diapedesis, and then they're going to go through the process of phagocytosis once they find that area of damage itself. And so in order to get to the area, they're attracted to the chemicals that are being laid out by the damaged tissue that is there. And then they're going to clean up things like the bacteria that may be here. They're going to clean up the damaged tissue into the area as well. And so all of those cells that have become damaged and they're starting to leak and things like that. If that infection that we may have going on there becomes great enough, we may end up with a fever. And so fever is essentially our body's way of turning up the thermostat. And so the thermostat gets set upwards, and this is going to allow for us to speed things up in the body. And so chemical reactions are going to occur faster as a result of the fever that is there. Much like the process of getting leukocytes into the area of an infection or tissue damage, fever works the same way. And so we're going to have chemicals, things like pyrogens, that are released by those leukocytes that are there, and they're going to allow for that chemical to circulate back into the blood, and they're going to turn up the thermostat. And so they're going to respond to the hypothalamus, or the hypothalamus is going to respond to them by turning up the body's temperature. And then all of those chemical processes that need to occur can start to occur at a higher rate because we've now turned up the temperature, and so chemical speed starts to occur at a much higher rate. If we know specifically what it is that is attacking us, this is where the adaptive or specific immunity comes into play. And so they only go after specific foreign substances. And so things that aren't supposed to be there, but they're also a very specific substance. And so it's the infection ABC or XYZ, etc. It's whatever that particular infection itself is, and it only goes after that particular type of pathogen itself. It can't go after another one. So if it's a white blood cell that goes after ABC, it will completely ignore XYZ that is there. And their job is to stop the infection, stop it from spreading, stop it from causing any kind of damage, neutralize it, get it to where it can no longer cause us any harm. And then in the process of doing that, we have basically two different processes that have to occur, and they both basically occur at the same time. And so we have our T cells once again, and those T cells are going to go at things in two different ways, as we spoke of before. We're either going to have antibody-mediated immunity, or we're going to have cell-mediated immunity, depending upon whether we're going directly after the potential pathogen, or whether we're going to, in a sense, go an indirect route and use antibodies. So when it comes to recognizing the potential for a pathogen that we have to find an antigen. And so antigens themselves are generally some sort of protein. They're a protein carbohydrate complex that's on the surface of the cell, or they are the viruses themselves that are being recognized as well, or the viral coding, depending upon the type of substance that's there. And that particular substance, this antigen that's there, has some important properties when it comes to our immune system. And so in order for a substance to be an antigen, that is going to cause a immune response, it has to be immunogenic. In other words, it's going to cause lymphocytes and antibodies to start to increase in numbers. And so we're going to start to increase the number of white blood cells and antibodies that are being formed, and we're going to start to attack that particular substance because it is reactive. And so the ability of that antigen to cause a reaction for our lymphocytes, our antibodies, and to destroy them, put an attack on them, and allow for us to get them taken care of out of the body itself. These antigens come in two major varieties. And so we have class 1 MHCs, or major histocompatibility proteins, and we have class 2 MHCs. And so class 1 MHCs are basically like our body's name tags. And so these proteins are found on all of our cells throughout our body. These are the ones that are referred to as being self-antigens. And so they are things that are going to be on all of our cells so that our immune system basically ignores it. But we also have the potential to have class 2 MHCs within our body, and these are the things that are going to cause an immune response. And so this is generally things like viral infected cells, bacteria, fungus, parasites, etc. These are the things that aren't supposed to be in the body. But they're also essentially things like tissues that have been given from another person. And so if a person has a tissue transplant, they're going to have class 2 MHCs on the surface of that tissue itself. We talked about this a little bit back when we talked about the blood and blood donation and the potential for a mismatch there in the blood types. So one of our responses is the response by T cells. And so T cells themselves, we said before that they mature in the thymus. And so when they go to the thymus, these T cells, they leave the bone marrow, and they're not a mature cell yet. They don't have the ability to attack antigens quite yet. They're going to have to go through essentially like a proofing process. And so this proofing process is going to either give us a negative selection or a positive selection. And so negative selection is basically for those cells that are recognizing our self-antigens too strongly. And so they see our self-antigens as being something that needs to be destroyed and eliminated. So that means that a negatively selected T cell needs to be destroyed. We need to get rid of that cell, because otherwise it's going to recognize our own cells as being foreign, and it's going to try to attack them. Positive selection tells us that that particular T cell, for the most part, pretty much ignores our own self-antigens. And so it's not going to have any kind of reaction towards it, or it's going to have just a weak reaction towards it. And this one can become immunocompetent. And it is immunocompetent. It's going to recognize whatever it is programmed for, and it's also going to become self-tolerant. It's going to leave our cells alone. It's not going to see them as being foreign, something that needs to be destroyed. Our B cells undergo this process of becoming immunocompetent in the bone marrow. So they don't leave the bone marrow until they are already immunocompetent once they're there. Since they are in the bone marrow, they can also potentially undergo some modifications. And so those cells haven't been released yet, and we can potentially change things up a little bit if they are too self-reactive as well. And so they're going to go through the same process of becoming immunocompetent and testing for their self-tolerance as well. But if they should happen to be essentially positively selected, that's there, or too strongly negatively selected, we have the potential to take that receptor that's on the surface of the cell and edit it. And so we're going to change up the proteins a little bit, rearrange the receptor, and retest it. If it becomes too reactive again, then we're going to destroy those cells. And so those ones that are self-reactive too much, once again, those cells are going to be selected against, and we're going to destroy those cells and not allow them to be released. If that rearrangement has now caused it to be, in a sense, normal again, then we can release them out into the bloodstream. So once we have these receptors and the cell is immunocompetent and we have the ability to ignore self-antigens that are there, we're going to have the ability to now recognize a particular antigen. They're going to be coded for, in a sense, for distinct antigens. And so a particular T cell goes after a particular antigen. A particular B cell goes after a particular antigen. Once they come in contact with that particular antigen, then they're going to attack. They're going to start their defenses against that particular antigen that is there, wherever it happens to be. When it comes to our B cells, the B cells themselves aren't going to actively work on destroying those antigens. They're going to produce antibodies. And so we're also going to create essentially a memory and a long-term defense against that particular antigen as well, so that we have the ability to recognize them in the future and destroy them if needed, if we should happen to come across them again. So since the cells were basically born, in a sense, or created with this recognition of particular antigens themselves, that means that it's the genes, not the antigens, that are determining which foreign substances our immune system can recognize. And so this is an important aspect of that. Essentially, we have to rely upon past history, in a sense, of things that our ancestors essentially have come across in order to have some recognition of the particular infection itself. So on the T cell side, T cells are fairly complicated structures themselves, and we're going to talk about just a small portion of the T cells that are at work here. And so the two big ones that we're going to talk about are CD4 cells and CD8 cells. And so CD4 cells or T4 cells, these are our helper cells. And so these ones release some of our chemicals that we're going to need, things like interleukin-2. They're going to cause more T cells to become proliferated, so we're going to make more T cells in response to them. And then we have the T8 cells, our CD8 cells. These cells are the ones that are going to actually go out and destroy whatever it is that is attacking us. And so these are our cytotoxic T cells. They're going to find cells that have been invaded by a virus, and they're going to destroy that cell and those viruses. They're going to potentially find tumor cells that we have created in the body. And these ones are also going to go after things like we talked about just a little bit ago, transplanted cells. And so foreign tissue from another person or another organism that has come into our body itself. And so that one we may actually want. So if we want it to stay around, we're going to have to suppress the immune system at that point. In addition to our helper cells and our cytotoxic cells, we also need to be able to recognize this particular infection once again down the road. And so we need to have some memory cells. And so memory T cells are going to be part of our response at a later date should we happen to come across that particular antigen sometime in the future. Sometimes it may even be something that is slightly similar to it, and we still get a response from it as well. So here we have our T cells. They went to the thymus to become activated, and we have our process of creating our helper cells, our CD4 cells, and our cytotoxic T cells, our CD8 cells as well. They're going to create memory, so we're going to get these memory cells as well. The cytotoxic T cells are going to go out and destroy whatever it is that we're happening to find. Our helper cells are going to help with the process of the chemical signals that we need in order to keep that infection response occurring. Speaking of tissue transplantation, when we do have tissue transplantation, this comes in a few different varieties as far as where we can get the tissues themselves from. And so if we donate tissue to our own cells, we have what we call an autograft. And so an autograft is essentially taking something like a tendon from one part of the body and putting it someplace else as a ligament, or part of a ligament someplace and putting it someplace else as well, or like a skin graft, something like that. Things are happening from within our body. We're getting the tissues from our own cells. Isografts are somewhat similar to an autograft in that the isograft comes from at least an identical twin. So both an autograft and an isograft are going to have very minimal chances of any kind of rejection of that tissue. Most transplants are allografts, and so allografts are going to be between people that are just not related, but their tissues themselves are close enough in terms of their antigens that they have that they're a tissue match. And so we have the potential that our body's going to not have as super strong a reaction against it and try and destroy it completely. Versus the xenograft is from a completely different species. And so this is oftentimes used in heart valve transplants, and so we can have a pig valve inserted at that point. So this does occur, and our body does have the ability to relatively ignore some of those tissues as well. Once a person has had a allograft or a xenograft uh, implanted into their body itself or transplanted into their body, we need to make sure that they don't have rejection of the organ itself. And so just like when we have a transfusion reaction for blood, essentially that's the same kind of a process where we can have our own body recognizing that blood as being abnormal, or a tissue being abnormal. And the way to make it so that it doesn't reject that organ is through immunosuppressive drugs. If it's suppressing the immune system to stop rejection of the organ, it's also going to suppress the immune system against any other foreign antigen. And so it makes them more susceptible to infection when they are on those medications. Our B cells create antibodies, and those antibodies come in a host of different protein combinations. And when we have those antibodies, we call them immunoglobulins. And so these immunoglobulins come in one of 5 classes: IgDs, IgMs, IgGs, IgAs, and IgEs. Each one is specific to a particular antigen. Each one is specific to a particular kind of infection that we have, and so they're going to become elevated. We're going to make them in response to specific kinds of things that are attacking our own bodies. So when it comes to the immunoglobulins, the D varieties and the M varieties and the G varieties are kind of our biggies as far as most infections goes. And so IgDs are going to be there in response to activating B cells that are there, and so they're found on the surfaces of B cells themselves. This is going to happen when we have infection. IgMs are going to be elevated very early on in an infection itself, and so these are some of the first types that are there, and they're generated by the derivatives of our B cells, the plasma cells. And so this is part of the reason why we get these early on. So we can kind of see where in the infection we potentially are. And so this is going to be during that primary infection itself. IgGs are unique because they can cross the placenta. And so IgGs give a developing fetus the some of the immunity from mom directly to the fetus itself. So they get a passive immunity coming in from mom because of those IgGs that are there. In addition, those IgGs are also going to be there in an important aspect of our first exposure to a disease, and then also our secondary response as well. IgAs are typically things that are epithelial related, so typically surface of the body. So this is skin, digestive tract, respiratory tract types of infections is where we're going to see IgAs become elevated from those types of responses. IgEs are for our allergic response. And so we're going to see them when we have histamine release coming from those IgEs. They're going to be in response to having basophils releasing those histamines that are there in the first place. And we're going to have this allergic response to that particular antigen that we found there, whatever it should happen to be. So when it comes to these antibodies, antibodies are similar to essentially our T cells and our B cells in the sense that they have a receptor on them. And so they have an ability to bond to a particular antigen that is there. And so when we look at a antibody itself, it looks almost in a sense kind of like a hemoglobin, in that we have proteins that are held together in 4 different components. So we have 2 heavy chains and we have 2 light chains that are there. And then we also have a component added onto them called the variable chain. And so the variable chain is this portion of the antibody that is going to change in response to the antigens that it is responsible for. And so depending upon the particular antigen that we are attacking, this variable portion is going to be different for each type of antigen. And so that's the portion that's going to be changed between the cold virus, the flu virus, COVID, etc. Those are the things that are going to be altered as we have those antibodies formed, and we're going to be able to then recognize them once again. So that when they do recognize them, they have the ability to bind to them, and so we can immobilize them. Once they immobilize them, they're going to basically neutralize them. They're going to stop them from being able to do whatever kind of normal process it is that they do that's there. They're also going to cause agglutination, and so they're going to cause essentially a clumping or a clotting of that particular infection, so it's going to be stuck all together in this particular area. And once they've done so, they have the ability to activate complement. And so complement is going to have the ability, and we'll talk about this in just a little bit. It's essentially similar to that of a T cell in that it's going to lyse the cells themselves. So it's going to destroy our microbes that we should happen to have that are there. And then the antibodies are going to enhance phagocytosis. And so they're going to enhance the ability of our phagocytes to come into the area and start to clean things up for us. And so it binds to the particular pathogen, makes it so that it can't do what it's normally supposed to do, makes them start to clump together once it's in that particular area, helps to activate complement, and that complement is going to essentially poke little holes inside the cells themselves, and then it's going to enhance our ability to destroy that cell through phagocytosis and the inflammatory response. So the complement process that we have here is a way that we help to destroy cells themselves that are infected and or cells that are bacteria. And with this, it's going to be, in a sense, kind of like a process similar to that of blood clotting, because we have a pathway that it follows. And so just like with blood clotting where we had 2 pathways, we have the same thing here in that we have the classical pathway, and then we have the alternative pathway for getting the complement proteins built and coming together itself. And so when it comes to the classical pathway involves our antibodies becoming bound to, so binding of the antibodies to our organisms themselves. And so we have to have recognition of that antigen-antibody complex, and essentially that antibody and antigen complex is then going to start us down the cascade or the pathway of binding up the proteins of our complement. And so we're going to get complement fixation, and that's going to then build those proteins on the surface of the cell, and that's then going to lead to the lysis of the cell. The alternative pathway does not require us to have the antigen-antibody complex formed. This is going to be in the presence of microorganisms that we have. This is going to follow us along a series of enzymatic reactions that kind of skips part of the steps. And so come to a picture over here. Here we have our classical pathway. We have our microbe. We have our antibody that is bound to it. And that begins our C1. And so the antigen antibody complex serves as the catalyst to activate C1. And then we're going to then activate C4 and then continue on down the pathway from there. And then once we get to C5, 6, 7, 8, 9, and then we have our activated complement, and it's all of the proteins are bound to the surface of our microorganism, and that then allows for fluid to either leave the cell or fluid to enter into the cell, and then the cell ruptures and bursts. The alternative pathway begins at C3, and so it begins essentially kind of skipping some of the steps there. And from C3, we get the activation of C4, and that then activates our C5, but it also activates C5 directly. And so we have the ability to begin this process without any kind of antigen-antibody complex to begin with. The whole idea of creating antibodies and creating memory cells allows us to have a memory of what it is that we have come across in the past, so that if we should ever happen to come across it again, we're going to be able to mount a much larger defense against it than we did the first time around. And so the first time that we come in contact with a particular infectious agent, some sort of antigen that we have, our initial response is going to take us a few days. And so that first few days, we're going to have a lag time, we're going to have a lag period. But then the second time that we come around to it, we're going to be able to mount an attack in a very short amount of time because we have essentially a primed system. And I wanted to get the picture here. So our first initial encounter with that organism that is there, we have our exposure here on essentially day 0. And our immune system is basically inactive for those first few days. And so this is where we're starting to feel bad. We may have our cough, our runny nose, etc. All those things that are starting to come up as far as our symptoms go. And in those first few days, we're not feeling too good. But then around about day 5 or 6 or so, somewhere in there, we start to develop things like antibodies. Our T cells are increasing in their numbers. We're able to start to defend against it. We've gotten beyond the primary, our innate defense, and we're now moving into our specific defenses that we have. This process then kind of peaks somewhere around day 10 or so. And as such, if you think about it, most kind of colds and infections and things typically last around a week or so. And so 7 to 10 days, perhaps by 5 to 7 days somewhere in here, you're starting to feel quite a bit better most of the time. And typically by essentially 10 days to 2 weeks, you're perfectly fine at that point. There's no lingering symptoms or anything like that from the disease itself. If we should happen to come across that same type of an infection, you pass it on to your family members, your colleagues, your work, etc., and it comes back around again, since we have seen that infection before, and since we have seen that particular antigen before, we can mount a very, very fast and huge response. And so within a day or two, we get this very large response that comes in, and this is where you may kind of feel like a tickle at the back of your throat, you might feel like you're coming down with something, but then after a day, it just goes away. And that's that potential secondary response has kicked in and given us a very large response to it. If a new antigen comes along, we start the process all over again. And so if a particular antigen has mutated, it's changed in terms of its appearance, and we don't recognize it again, this is where we get sick once again. We end up getting sick another time, and the process itself has to start all over. And we go through the same processes again. If we should happen to come across it again, we're then going to increase those numbers once again, and then they're going to fall off. This extended level of increased antibody formation is what then gives us that longer term immunity. If that amount ever gets back down to 0, then we may not recognize that particular infection again. When it comes to immunity, we do get immunity in two basic ways. We either naturally acquire it or we artificially acquire it. And so natural acquisition of immunity is one is that we have an infection. We get the infection because we've been infected by a particular pathogen that's there. And that's going to be an active process. Our body has to fight off that particular pathogen. We can also get it passively with naturally acquired immunity as well, in that we can get it from things like breast milk and also those that cross the placenta there. Artificial immunity comes from the advent of vaccines. And so vaccines have a couple of different ways that they can function. We can essentially make our body have to go through the process of attack and growth of antibodies itself and give them a active process. This is going to be with what we call attenuated viruses oftentimes. So they're either dead or they are inactivated so that they don't cause us disease. Or we get the immunoglobulins directly. And so depending upon the type of vaccine that's been developed, depending upon the type of process that's there, determines which way our body does it. And so both passive ways, our body does not have to actively fend against the particular infection itself. We're just given the ability to do so without our body having to go through that process. And with that, we end up on our immunity and continue on from there next time.